All right, well, we are going to go ahead and get started. So thank you so much for being here. My name is Ann Coy. I am Healing City Baltimore coordinator, and I think I have the best job in Baltimore. I get to work with all the helpers in the community to think about how we can reduce trauma across the city and think about how we can increase healing and largely leverage work that's happening and imagine new ways for us to have systems of care and connect people in the community. So I was saying some of you were on. I love these gatherings. I love to be able to gather with people who are often working as helpers across Baltimore and are doing incredible work in your own spaces. I also love that we get to learn from helpers within our community. And so today, I'm going to introduce Renee. I'm also going to give Amy Greensfelder some time. Amy is from the Pro Bono Counseling Project and is a partner in sponsoring these lunch and learns. So actually, Amy, maybe I'll turn it to you for a minute and then I'll introduce Renee and we can hand it off to her.
Great, thank you, Ann. My name's Amy Greensfelder. My pronouns are she, her. I'm the social worker and I'm the executive director at the Pro Bono Counseling Project. Pro Bono Counseling Project is so pleased to be able to partner with Healing City to offer continuing education credits for these events. And so if you are a social worker, professional counselor, marriage family therapist, psychologist, you'll be able to obtain a continuing education for attending. To do that, you just need to remain on for the duration of the event. If you have a brief interruption with your internet, that is fine and you're able to get back on. But sometimes if you're on for an offline for an extended period, we're not able to provide the continuing education. So we appreciate your assistance with that. And I just want to share just a touch about Pro Bono Counseling. We provide free mental health counseling. We have been around for 30 years. We have mental health counselors throughout the state, some of you whose names I recognize because you've volunteered with us in the past or continue to volunteer with us, and we appreciate you for doing so. And if you are interested in volunteering, by agreeing to see 1 or 2 clients every year on a pro bono basis, you get access to a whole suite of free continuing education. So we offer over 50 hours every year of free continuing education on a whole range of topics. I'm going to put some contact information in the chat box if you're interested in learning more about volunteering. And then if you're just in touch with folks who maybe are interested in counseling but are having difficulty accessing care, we can help folks with getting connected to volunteer licensed mental health therapists for free therapy. We also offer a mental health warm line that folks can call on weekdays from 10 a.m. to 8 p.m. and on the weekends too from 10 a.m. to 6 p.m. And that mental health warm line gives people phone access to a mental health professional for brief telephone-based support. So that's a great resource as well. All of our services, we have bilingual folks supporting all of our services, and we also offer interpretation for languages that aren't covered through our bilingual staff. So I'll put some stuff in the chat box for you about links to those services and how to enroll as a volunteer if you're interested, and how to link up folks to our services. But we really appreciate you coming today, and we're excited to partner with Healing City to offer the continuing education component.
Thanks, Amy. We so appreciate you all as a partner in this series. So today we are so thrilled to have Dr. Renee Johnson with us. Dr. Johnson is faculty at Johns Hopkins University. Her research focuses on how psychosocial factors shape risk for unhealthy alcohol and drug use among adolescents. Today, she is going to be sharing with us a presentation titled "Using Data from the Maryland Youth Risk Behavior Surveillance Survey to characterize Adverse Experiences Among Youth." So Dr. Johnson, I'm going to turn it over to you for the remainder of the hour. We'll be here to help support in the chat, but you're really the expert here. So I'm going to turn it to you.
Thank you. I now am going to share my screen, and I think it's going to work. what was I going to say? So I am sort of, before I do that, I am wondering, among you all, who even knows what YRBS means? You can sort of unmute and say, I know, or I don't know, or put a reaction in the things. Okay, so some people don't. Okay, this is good. Wow, this is awesome, because I sort of work with this data all day long, and it's just nice to talk to people who don't even know what it is. So, all right. So this is the my presentation. I'm going to look at Maryland YRBS data, and YRBS stands for Youth Risk Behavior Survey. It's a survey that's been going on for years, since 1990, and it is the primary way that we gather population-based information about adolescent health. And it really focuses on behaviors. So, how often did you drink? How often did you smoke weed? Did you get into a fight? Sort of discrete, crude things like that. But what you'll learn today is now Maryland, because of advocacy from social workers and the movement in Maryland to think more about trauma responsive care, has included some indicators of adversity on the surveillance survey. So now for the first time, we really get to not just look at risk behaviors, but also the adversity that shapes those risk behaviors. So with that, I'll get started. Oh, boo, okay. I'm sorry, I'm now seeing that my PowerPoint is a little funky. Hold on. Yes, okay, now we're good. Okay, so usually I'm trying to convince public health people that adolescent emotional and behavioral problems are increasingly viewed as a response to trauma and adversity. But because of the work that you all do, you could probably be telling me about this. So in public health and in adolescent health, we've had a really big focus on measuring risk behaviors, sex before age 13, and how many fruits and vegetables you eat. And the point I'm trying to make with this first slide is that it really makes sense to have a clear understanding of how many youth experience trauma and adverse experiences to lay a foundation for understanding their risk behaviors. So nearly 1/2 of Americans have been exposed to at least one adverse childhood experience before turning 18. And this contributes to a broad array of problems spanning physical health, mental and behavioral health, and psychosocial functioning. So, in public health, it's easier for folks to get a measure of how much a young person is drinking alcohol. That is easier to obtain than it is to find out how many youth have a parent who's in jail. So learning about behavioral problems is easy, and learning about adverse experiences is hard. So we're very mismatched in our efforts at surveillance. But the good news is that the 2018 Maryland Youth Risk Behavior Survey included items to monitor the prevalence of adverse childhood experiences among high school students in Maryland. And we can now use those measures to assess associations between ACEs and behavioral problems. They included 5 adverse childhood experiences. And certainly there are more than these, but the idea with surveillance is you want to keep it the same every year, the same across locales, and as short as possible. So it's a really difficult process about deciding what to keep in and what to remove. So the 5 adverse experiences that were include parental substance use and gambling, parental mental illness, incarceration of a family member, food insecurity, and caregiver verbal abuse. So let me tell you a little bit about the Maryland YRBS. It's administered every 2 years in Maryland public schools in all counties. It includes items on physical activity, nutrition, violence and fighting, substance use, and demographic factors. And it is the primary surveillance system for monitoring health and risk behaviors among adolescents in the state. And because this project is done in collaboration with CDC and all the states use the same questions, it enables comparisons in risk behaviors across states. So some of the main uses of this are to document progress toward objectives. So if we have the objective that we want young people to eat more fruits and vegetables, we can monitor it progress based on YRBS data. We can evaluate school and community-based programs and interventions. We use that data to guide planning and decision-making. And Maryland has Maryland has sampled youth for the state YRBS so that we can look specifically at counties. So you can get county specific information on any of the questions in the YRBS. All states, so I'll say that all states have to use standard questions, but you have a little bit of leeway. States can include additional questions within reason if they're approved by CDC. So Maryland has the ACEs question, and a couple other states will be including them on this survey in the next iteration of the survey. Maryland is also unique. Our YRBS includes quite a lot of tobacco questions. So it is also called the YRBS YTS because it includes tobacco use surveillance as well as youth risk behavior surveillance. Okay, so here are the 5 items on adversity, and here is how they are measured. Caregiver verbal abuse. Does a parent or other adult in your home regularly swear at you, insult you, or put you down? You'll notice that all of these questions are yes/no questions, and the idea is that it should be a low response burden. You should be able to answer these quickly and not have to sort through strongly agree or disagree, or think of number of times or things like that. So it's crude and there are certainly limitations, but it gives us some good ideas. And I created an additional variable to measure how many of these variables young people had. So they could have none of the 5 ACEs, any 1 ACE, 2 ACEs, or 3 to 5 ACEs. Any questions so far? I can't really see that. I can look, and let me take a break and look at the chat. Was that part of our tobacco settlement? I'm not sure. I wouldn't be surprised if it was.
Yeah, thanks.
Mm-hmm. Okay, so I wanted to tell you about the analyses that I did. And these data, if you want the state data, they are online and it's very easy to get this information from the CDC's portal. But if you want to look at the adverse child experiences questions, you'll have to go to the state, but it's very easily available. And I can give you the contact information for Nakardi Jallah in MDH, who makes the data available. I'm also really, really happy, and I really mean this, to give you some cuts of data if it would be interesting to you or would help inform your work. I have many students who could, would be happy to summarize some data. So the data that I'll do today are, I'll answer 4 questions with the 2018 data on adversity. What's the prevalence of ACEs among Maryland high school students? How common are they? How are they associated with emotional and behavioral problems? How does the prevalence of ACEs vary across population groups? And then what contextual factors are associated with increased risk for ACEs? And because we're in Baltimore, I also put together one-page information about ACEs among Baltimore youth specifically, which I'll also show you. Okay, so this is some of the methodology of the survey. It's a multi-stage cluster sampling design. And what that means is that we chose counties and then randomly, well, we chose all the counties, and then within counties, we randomly chose schools, and within schools, we randomly chose classrooms. There was a higher than 60% response rate for each county and for the state as a whole. And here is the survey, and I think we'll have time. Famous last words, if I'm like rushing at the end to try to finish it, I'll regret doing this. But so here's CDC, and here's some information about the survey. And you can sort of see what it looks like. So, you know, folks get this printed out and then they just bubble it in. And that's something students are generally very used to doing because they're often doing standardized tests. So I looked at some emotional and behavioral problems in the survey, including emotional distress. And this was asked by asking, have you felt sad or blue over the past 2 weeks? Poor school performance. There's a question that says, did you get mostly A's, mostly B's, mostly C's? Past year suicidal ideation, past year fighting at school, any past 30-day use of alcohol, and any past 30-day use of marijuana. And I also looked at variables that we know are associated with risk behaviors, including grade level, race and Hispanic, Latino ethnicity, sex, and county. Okay, so I'll get started with the first question. This is the prevalence of ACEs among Maryland high school students, and the point estimate, so right here for 29.2, that's the general prevalence, how common it is. So you would say 29% of high school students indicated that a parent had a mental illness. And this confidence interval shows you about how accurate we think that is. So the wider it is, the sort of more error there might be in estimation. So what we found was that 29% of high school students in the state reported mental illness of a family member. 23% reported parental gambling or parental alcohol and drug use. 23.5 reported that they had a family member in prison or jail. About a fifth reported caregiver verbal abuse, and 17% reported food insecurity. So this shows the number of ACEs among adolescents. And the main takeaway is that the majority of high school students in Maryland report at least one ACE. Just 43.7% reported not having any adverse experiences. 25.8% reported one, 15% reported two, and 15.4% reported three or more. Okay, any questions so far? Okay. So then the next question is, how are ACEs associated with emotional and behavioral problems? So what I did here was do sort of a 2x2 table and then estimated some prevalence ratios. So for those of you who do statistics, this is a multivariable logistic regression. And I adjusted for race, ethnicity, sex, grade level, and sampling design in these models. So what all three of the slides I'm about to show is that ACEs are strongly associated with behavioral problems. Now, this isn't news, but it is good to have this information for this particular population, because we know it from big longitudinal studies. I'm sure you've read the Felitti articles on adverse childhood experiences. There's a long history of research in this area, but now we can have it at the county level and among the kids that we all serve. So I've just included 3 ACEs here because I didn't want to throw too many numbers at you. So what this shows is that among young people who reported poor school performance were 2.04 times more likely to have a family member who had been to prison or jail. Young people who reported fighting at school were 2.59 times more likely than those not fighting at school to have had a family member go to prison or jail. And it's the same with caregiver verbal abuse and parental gambling and substance use. Young people with poor school performance were 1.3 times more likely to report caregiver verbal abuse. Those reporting fighting at school versus not were 2.2 times more likely to report caregiver verbal abuse. And these findings on family member having been to prison or jail is consistent with emerging research. Nia Hurd-Garris at Northwestern has been looking at the impact of having a family member in prison or jail, and just had a paper come out in JAMA Pediatrics maybe last month. So it's a real under-recognized issue among many young people. Okay, and we see similar results. And one thing I wanted to highlight was how high these odds ratios are for caregiver verbal abuse and suicidal ideation and emotional distress. So what we're seeing is that caregiver verbal abuse increases risk for a whole host of things, but in particular, it really is associated with a greater risk of suicidality and feeling sad or blue. And then finally, these are the substance use behaviors I looked at. And again, having a family member who's been to prison or jail, experiencing caregiver verbal abuse, or experiencing parental gambling or substance use is strongly associated with increased risk for any past 30-day alcohol use or past 30-day marijuana use. Okay, so now what I want to do is just look at differences in the prevalence of ACEs across different groups of young people, just to get an idea of who is most vulnerable. So what this slide shows is the difference in the prevalence of ACEs, specific ACEs, by sex and sexual gender minority status. So boys versus girls, and sexual and or gender minority versus heterosexual cisgender. So let's look at food insecurity. The reported prevalence of food insecurity among boys and girls is pretty much equal, 16 among boys, 17 among girls. Same with parental substance use or gambling, about 23% among boys, 25% among girls. And also same with family member having been to prison or jail. It's about 24 to 23. However, these three variables show a real difference, with boys having less risk. So girls are significantly more likely to report parental mental illness. 34% of girls indicated parental mental illness and 25% of boys. Now, part of that, oh, I'm right here. Part of that might be about, discord between moms and daughters, and girls labeling their mom as having a mental illness. And there may be other explanations. Caregiver verbal abuse was also higher among girls, 23%, than boys, 18%. And again, this might be hinting at parental discord, and folks who do adolescent health know that girls have more arguments with parents than boys. And then finally, when we look at none of the 5 ACEs, boys are more likely to report having none of the 5 ACEs, whereas girls are, 40% of girls report no ACEs. Okay, and then we look at sexual and gender minority status. All of these differences are statistically significant. So sexual and gender minority young people are more likely to experience food insecurity, more likely to report parental substance use or gambling, more likely to report parental mental illness, more likely to report family member in jail or prison, much more likely to report caregiver verbal abuse, and also less likely to say that they haven't experienced any of these 5 forms of adversity. And it's not entirely clear to me why SGM young people would report higher levels of food insecurity. Some of these are very clear. There's probably some parental rejection that comes with identifying as sexual or gender minority. And so that might be behind this caregiver verbal abuse estimates. But some of the findings are less clear. And that's all the data for you. Okay, so those are 2 groups. And then next I'll look at race. And this is a really busy slide. So I'm going to take it one day at a time here. So the title, Prevalence of Adverse Childhood Experiences Among Maryland High School Students in 2018 by Race and Ethnicity. So if you look here, the red dots are white, orange are Black, Latinx are green, Asian are purple, multiracial are blue, and other are yellow. So this slide shows the prevalence of each ACE and of multiple ACEs by race, ethnicity. And the main takeaway is that ACEs are differentially distributed across population groups. Okay, just focusing on Black students for now, the most common adverse experience among Black young people was having a family member who's been to prison or jail. 32.2% of Black students reported that. So about 1/3 of Black students in the state of Maryland say that a family member has been to prison or jail. When you look at white students, the most common adverse experience was mental illness of a family member. So young people reporting that a family member had a mental illness. Asian students were the least likely to report every single ACE. So they had the lowest prevalence of food insecurity, of parental substance use, of mental illness, of family member having been to jail, and on and on. So this is really quite fascinating and likely relates to patterns of immigration and what Asians come to Maryland. So this is all the same data, but what I did was I just took out one block. I took out the block of high school students reporting that a family member has been to prison or jail by race, ethnicity. And you see about 17% of white students, 32.2% of Black students, 23.4% of Latinx students, 7% of Asians, and 30.3% of multiracial students. And one thing I did was look at what are the race groups among multiracial young people, and the most common group was Black, white, biracial. So about 60%, more than 60% of folks in this multiracial category say that they are Black and another race. So if they're talking about a parent who has been to prison or jail, then it's likely, it's highly likely that that parent was Black. And so now you can just see this really high disparity in having a family member who's been to prison or jail among Black, Latinx, and multiracial young people. It's an adverse experience that nearly doubles the risk for many emotional and behavioral problems. And I've mentioned, I mean, we could look at all of these. There's some people in Maryland who are looking at the food insecurity adversity type more closely. But one thing that I think about with the prison or jail is this idea that how are we protecting these young people? We know the impact of having a family member incarcerated is a really big deal. It impacts finances, it impacts social support, it leads young people to feel stigmatized. And yet I think many of these students are going to school every day without any sort of support for this experience in their life. That's really hard. So just something I hope we can think about. So what I'm going to do now is pull up my Baltimore specific slide. Can you see this? I'll make it bigger. But so what I did, oh, I have something in the chat, let's see. Okay. Thank you, Anne. What this slide shows is just Baltimore City. So we restricted the Maryland YRBS to the Baltimore City YRBS. And you see that 79.2% are Black, non-Hispanic, and another 8% are Hispanic of any race. So the majority of these folks are Black and Hispanic, Black and or Hispanic, and slightly more females than males, and slightly larger percentages of 9th and 10th graders than 11th and 12th graders. But here's what I wanted to show you, the level of these ACEs in the city of Baltimore. So 26.5 report food insecurity, 24.9 report parental gambling or alcohol use, 27.6% report mental illness of a family member, 46% of high school students in Baltimore report a family member, someone in their household has gone to jail or prison. And then about 20% report caregiver verbal abuse. About 30% reported one of these 5 ACEs, 21% reported 2, and 20% reported 3 or more. So what I did there was then look at heroin use and non-medical prescription opioid use and injection drug use. And what you see is a stair-stepped result. So if you didn't have any ACE, among those who didn't have any ACEs, 9%, just 9% of them reported any lifetime use, any lifetime non-medical use of a prescription opioid. If they had just one ACE, about 18.7 reported lifetime use of non-medical prescription opioid. And then that number jumps to 22.5 if you had 2 ACEs, and jumps even higher to 26.2 if you had 3 or more ACEs. Now, heroin use and injection drug use are much less common than use of non-medical prescription opioids, but you still see this same stair-stepped increase. The more adversity you experience, the more the larger the percentage of use of substance use. Okay, so I need to now go back to my slides. I see some good conversation in the chat, so I'll try to finish up so we can have a little bit of time to talk. So this last thing is something that I am really interested in. My last question is about this idea that we in public health focus on emotional and behavioral problems. And I hope I've convinced you, and you probably already felt this before, but that adversity shapes the emotional and behavioral problems that young people experience. But I think the next step that I want to take is, what are the structural factors that shape the adverse experiences that youth have that then lead or contribute to their emotional and behavioral problems? And I think what I'd like to do next is think about the structural risk factors and then work upstream to develop and implement policy and structural interventions. So the question that I pose is, what contextual factors are associated with increased risk for ACEs? One area to look at is racial disparities in the criminal justice system. I think we do think about these in terms of how they impact adults, but it's less common that we're looking at how they impact young people. So Black Americans make up 40% of the incarcerated population, despite representing only 13% of the US population. And incarceration impacts families, and it's critical to understand incarceration experiences to better understand adolescent behavioral health. So the other thing that I want to add is that incarceration is a real issue for rural populations as well. I don't think I have the data, or maybe I do. Maybe I'll show it in a couple of slides. I can't remember. But a lot of what's happening in rural areas, and specifically in rural Maryland, is that there is not enough treatment for substance use disorder, no resources for people who are using drugs. So de facto, the criminal justice system becomes the largest treatment system for people who use drugs, and there are just incarcerating and getting people in rural areas who use drugs into the criminal justice system rather than into systems of care. So, in summary, we found that Maryland high school students with a family member who'd been to prison or jail are more likely to report emotional and behavioral problems. And this is consistent with existing research. 2, we observed that more than 25% of Black and/or Latinx students report having a family member who had been to prison or jail. And therefore, my conclusion is that criminal justice system policies and practices are structural determinant of emotional and behavioral problems among adolescents, especially among Black and Latinx youth, and rural youth, I would add. So this is a paper that a student of mine is working on, and we wanted to think about area level socioeconomic disadvantage and how it's associated with adverse childhood experiences. So Shaheen Karani developed this measure, adapted this measure called the Area Deprivation Index. It pulls many different indicators from the census and puts them into a composite measure, and every county in the country can have like a value for how deprived they are. I think the scale goes from 0 to 100, and we broke Maryland counties into these 5 quintiles, with the darkest green over here, like DC suburbs, being the least deprived, then the red, including Somerset County, being the most deprived, the orange being the second quintile of deprivation, and so on. But you see, like, these are very crude, and most counties are in the lowest level. So instead of using doing analysis with the quintiles, we kept that variable continuous. So here's some information on the statistical analysis, and I'm happy to talk more about it, but I'll really just walk you through the results. So what we found was that in counties with a lower ADI score, young people were 10% more likely to report food insecurity, 5% more likely to report parental substance use or gambling, 14% more likely to report a family member in prison or jail, and 8% more likely to report at least one ACE. When we looked at rural counties, we found that youth in rural counties were 25% more likely to report parental substance use or gambling, 35% more likely to report a family member in prison or jail, 25% more likely to report caregiver verbal abuse. And the other associations that I didn't show were not statistically significant. So the lessons learned from this whole presentation and this experience is that ACEs are common and differentially distributed across groups. We can really learn about like what is contributing to ACEs when we look at the patterns across different groups. ACEs greatly increase risk for adolescent risk behaviors, and contextual factors, including area level deprivation and rural residents, are associated with increased risk for adversity. The data suggests that social and structural factors, such as rural county and area level deprivation, play a role in determining the adversity that youth face and the prevalence of behavioral risk factors. So my final conclusion is that if we really want to do primary prevention of adolescent risk behaviors, then we should really move upstream and think about efforts to address structural factors, such as increasing food access, ensuring family financial support, reconsidering imprisonment as a sanction for criminal behavior, thinking about alternatives, and other structural level interventions like that. I think working on structural and contextual factors is a real critical strategy for primary prevention of ACEs and for promoting adolescent health. And that is really all I have to say. Here is my funding. Nakardi Jallah is the person within MDH you should talk to about getting the data. And here is my contact information. So thank you so much. I am going to now stop the share and look at your faces, and I would love to just chat and see maybe how this can be useful to you. Okay, so Kelly, thanks for your comment.
Yeah, so my last comment, so first of all, hello and thank you. I am deeply indebted to you for this research. It really, it's on the one hand, deeply disturbing and disconcerting to see that so many of the young people are are grappling with this in their day-to-day lives. And here in 2018, we have no mention, right, of the slow-moving pandemic of COVID. And who knows how that will factor into ACEs and people's life chances. So this is really completely a revelation. And I really liked the point that you make about incarceration of parents and how that the number staggering 46% in Baltimore City. We kind of know that as a hunch, but then to know that number is really helpful to me. And it gives me inspiration, I think. Part of this also for me is about the over policing, right? So it's about who gets incarcerated, but also who is over policed. And so thinking about that as we address those systemic issues and the legacy of the white supremacy of our police force when we don't even have local control, is something that I really want to think about. And then I guess one kind of follow-up question for me that I don't think was part of this study is, do you know if any states include as in their ACEs questions and those like where you can tinker with them a little bit about justice legal system involvement for young people? And so that is like, I saw the one about fighting in schools, which we know can lead to the charge of disruptive behavior, which for many children throws them into the Department of Juvenile Services. I was wondering if there's any figures about that specific contact with legal systems for young people for themselves as being charged. Thank you so much for this.
Oh, you're welcome. So when you were talking about incarceration, I have to say, I sort of got this idea about thinking about the experiences around having a family member in prison or jail from a colleague in Southern California. And she is a research social worker. She was at USC and was working with a community, and this community had a very high proportion of kids whose parents were in the military. And this was maybe 10 years ago when there were just tons of deployments. So the kids were having a lot of emotional and behavioral problems, and it was related to a lot of deployments and parents coming back, suffering from different things. And she worked with the school district to sort of rethink the whole school, to understand when, so that teachers and other adults understood when kids' parents were being deployed, when they were coming home, and really just restructured how the school operated to deal with this giant traumatic experience. And I thought the prevalence of poor kids who have parents in prison or jail is just as traumatic and higher than the prevalence of those in military affiliated families. And I just think they go to school every day without any support. And I really just think the best thing we can do for these kids in the short term is help them bring that shame down and support their families. So I just really hope, I feel like that's where my social work experience ends, but I see the data and I just want to hand this idea off and hope that folks in your communities will sort of rethink that. And then the other thing you were talking about, so there's a lot of research on the school to prison pipeline, and I have to confess that I don't know that data super well, but I know it's out there. I wonder, I'd love your feedback. So I'm interested in looking at social and structural factors and the extent to which they are associated with adverse childhood experiences. And, I put together some odds ratios. I wonder how that's helpful to you. If that's helpful to you, does it help you in advocating to the city, to the state, to schools? What kind of findings would be something that those of you in this Zoom meeting could sort of use to make a difference.
So I'll jump in thinking about the presentation we had yesterday for Healing City, which was linking food insecurity and transportation. So I think for some of us who work, like again, and thinking about some structural issues and thinking about Baltimore City, but then also the greater region, right? There are kind of two related issues there, I guess, that come to my mind. And one is the correlation between living in food opportunity zones, right, which is a way to like cleaned up way to say food apartheid areas, and then also the lack of transportation to be able to get to a place to have healthier choices, right? So that relationship of what we know, if you're in a food desert or a food apartheid zone, then that what the young people are saying about their own experiences with food and hunger is also affected by the placement of supermarkets, but also then the ability to travel to a place. So I think we could have some allies in transportation planning and for people who work on transportation equity, and the strong desire to bring back the red line. And the proposition of the red line. So it's like 2 to 3 bus stops away. It's like, but to me, it's really adjacent to what the childhood experiences are, or for young people, and thinking about transportation and food. So that's really, I think, helpful for me to understand.
I appreciate that. And I also, it makes me think about opportunities to get involved in pro-social activities. If there is inequities in transportation, then kids sort of can't get around. They can't go to, gymnastics or track club or something if their parents aren't able to drive, or, don't have money for gas, and the bus is so complicated and it takes as long to get there as it does to participate. So I actually really like that. That's worth
it. Or so then again, another step further, it takes an hour and a half for some of our children to get to school in crosstown buses. Yeah. Right. And one of the things that happens on buses is fights. Yeah. Or, the disrespect that leads to something that people carry into school with them. So that the bus can be the seed and source of conflict and great frustration, quite apart from the amount of time it takes a young person to travel across town to get to their school. So for me, the transportation continues to be a big piece, even though that's not my bread and butter job, right? But it's so bound up together, I think.
Yeah, I think that's important. I actually found that when I was working in Boston in youth violence prevention, that the buses were where lots of fights broke out. And the buses were the transportation system for high school students in Boston. So they just have free passes. Oh, same here. Okay, so. Okay, well, thank you. I really appreciate this conversation, and I'm just so glad you all hung in there with me. I hope you get in touch with me if you would like to talk more about this. I'm around, and good luck in your work.